and I'll give you the access code and we'll get going. Okay, if everybody's ready, you got your second devices, everybody's got it all pulled up. Cassandra, I just need you to turn on your screen for me, please, my friend. All right, we'll give her another minute here to turn her screen on and then we'll get started. You are awesome. Okie dokie. We got everybody on screen, so I'm going to give you guys the access code. The code is LAST with a capital L. LAST, last with a capital L. All right, I think everyone is finished up. So if you guys want to turn your screens on, we'll go ahead and get class started. Wonderful, wonderful. Like always, if you guys have questions over your quiz, please email me. I would love to go over things with you. We can review the quiz answers and stuff or questions together if necessary. I'm not supposed to go over each question individually until all other sections and classes have taken the quiz. So I can't like go through it um, specifically. Hold on one second. I'm not able to meet directly after class today. I have a other meeting scheduled with a student. But other days, I'm more than happy to stay after class with you guys. So, like always, I want to go over what we have going on this week, and a couple other like housekeeping items. And then we'll jump back into our material for from last week and this week. Okay. So let's jump in to Canvas. Alrighty. So let's go down here to week 8. So this week you guys have discussion post number 4 that your initial response is going to be due tonight, with the 2 responses to your peers due by Sunday night. You have your sim chart, your normal newborn sim chart that is due by Sunday night at midnight. And then also you have your NCLEX questions for week 8 that are due as well. Okay. So make sure you guys get all this stuff done. At the end of the semester, I'll turn your homework weight back on. That way you guys can see your full grades with the after your HESI remediation and after your HESI exam. Okay. Let's look ahead a little bit to week 9. So week 9, we have our last exam of the class. Okay. So week 9, we're going to be spending most of our time taking our exam and then reviewing some stuff from week 9 content, and then maybe potentially reviewing for HESI at the end of the class as well. Your week 9 assignment is a little bit different because you have this HESI RN maternity assignment exam. Okay. This is not your HESI exam. This is a practice exam, but it is still worth points. It is still a homework assignment that we give you guys a grade for. This maternity assignment exam, as well as the one that is in week 10, the HESI RN maternity practice exam, these 2 exams, you guys should be able to use your materials. You can use your textbooks. You should be able to look stuff up. You can take your time. These are some things that I want you guys to spend a lot of time on so that you can get the most amount of points possible, okay? Because this is really good practice and this is really good review for your HESI exam that you're going to be taking week 11, okay? So again, this HESI RN maternity assignment exam, this is not your HESI exam. This is a practice exam that is a homework grade, but I want you guys to take a lot of time on it and spend a good amount of time on it so that you guys get a good grade on it, okay? Moving forward just a little bit ahead of that, I will be sending out an announcement that has the date and times that each of your guys' respective campuses are going to be offering your exam for your HESI, okay, for week 11. You guys will be responsible for registering for that exam, for signing up, and making sure that you have all arrangements made because you don't test with me. You guys test on campus, okay? So I will make sure um, I will make sure to have the times and dates posted for when you guys should be signing up on your campus, and then you guys are responsible for signing up yourselves, okay? Please don't put that off because I don't want you to miss like the deadline and then you're not able to take your HESI and then that just sucks, okay? Week 10, we mostly spend reviewing For HESI, we don't really cover new content. It's all going to be like I'm going to have a bunch of case studies that we're going to do. We're going to play a bunch of Kahoot review games. It's going to be a big study session. Week 11, we don't have class because you guys are taking your HESI. And then we'll talk more about week 12 the closer we get to that, okay? Because week 12 is a totally different thing. So that's like a brief snapshot of the rest of class, guys. We're almost done, which is just crazy to me. I feel like we just started. For this week, we went over our assignments. The other thing is there's still a lot of review sessions that have not happened yet that you guys should sign up for, at least one if you can make it, because I think that they are really beneficial whenever you're studying for your exam. Okay. There is one thing in your announcements that I wanted to show you that I think will be helpful as you guys are studying. So when you go into your announcements page and you scroll down and you come to, where is it? Here. Exam 3 study session schedule, study material, and recordings. This is where we post everything that from the other instructors and the other campuses for their review session. But if you scroll down here and you see where it says PowerPoint, Blueprint, previous recording, this concept review for exam 3, I want you guys, as you're studying, to use this as a jumping off point because I think it's really awesome. Okay. We're not allowed to call these things study guides. Okay. So I'm going to call it a concept review. And you can look at it, but it is very helpful. Okay. So let's look at it through it briefly. All right. So here we start off with a couple of short answer questions. So what are primary physiological systems that undergo adaptation during the transition to extrauterine life? Talking about the newborn. So then it goes into it. The newborn must undergo significant changes in cardiovascular and respiratory systems to support independent breathing and circulation. And then it talks about these. So it gives you like kind of example like topics to review, and then like key items to focus on underneath each topic, right? So then the next one, which specific assessments are prioritized during initial nursing care of a newborn? Initial physical assessment, followed by body system, neurological assessment, so your reflexes. Then it talks about your gestational age. So this is kind of going through with you on things like to study, because I know in this class you guys get a lot of information. It is a lot of stuff crammed into 12 weeks. Okay, so this kind of helps itemize the things that you should be focusing on and go into how much detail you should be learning about each topic for your exam. Okay, so let's keep going. We got our answer key to those short answer questions. These essay questions here give you things to look up. We don't provide the answers for this, but if you guys start with these essay questions and you want me to review what you guys have gotten while you're studying and reviewing this, I'm more than happy to do that. So like discuss the importance of neurologic and gestational age assessments in identifying potential birth injuries and long-term developmental risk. So if we have a baby who is post-dates and who's going to be a big baby, we know that they may be at a higher risk for a shoulder dystocia. And we know a shoulder dystocia, one of the common things that can happen from that is a fractured clavicle fracture. So how does a gestational age kind of identify those birth injuries, right? If we know they're post-dates, what are they going to look? What could they be at risk for? So go through these, try to answer them to the best of your ability. If you want me to review your answers that you've gotten, I'm more than happy to do that. The last part of this little concept guide here are some key terms, okay? This isn't like just study the term and know what it means. It is giving you things that are like topics that you could potentially see on your exam, right? So, birth injuries. What are we talking about when we're talking about birth injuries? If we know a baby has a cephalohematoma, they are at an increased risk for hyperbilirubinemia. If they have had any type of birth injury, they're at a high increased risk for hyperbilirubinemia. So, kind of go down through this list, make sure you understand what it's talking about, focus on these big specific things as you're studying for your exam. Okay. But this is a really good resource for you guys, and I would highly, highly recommend you using this to review for your test. I met with a few of you. Um, I met with a few of you before exam two, and I had recommended you guys use the concept review for exam two that was posted in that announcement. And the people that I met with overall did really well on exam two for the most part. Okay. So I think that this is a really good thing to use, a good resource. Any questions so far about concept guide, studying for exam three, what we're doing? You guys all feel pretty okay with the plan? Know what we're doing here? Awesome. Maybe we're on the same page. I hope I know what I'm doing. Okay, so last week we got most of the way through our week 7 PowerPoint. We only have a little bit left to go over with that week, and then we'll jump into week 8 content. That PowerPoint does not take super long either. So what my plan is, I'm not planning on taking a break again today if you guys are okay with that, so that we can get out at like 8 o'clock. If we get through both PowerPoints, we're going to play the Kahoot exam 3 review that I have. And then that should take us to the end of class. My last class, I had a couple students who stayed over to play and finish the review game. So that's always an option if you guys need to. But let's go ahead and jump in to our week 7 PowerPoint. I'm going to need you guys to remind me where we left off. So I'll just start from the beginning and we'll go from there. All right, we did our review. We started our scenario. Did we do this slide? Yeah. Did we review APGARs all the way through? I believe we went through this, did we? Okay. Um, did we start talking about hypoglycemia? Did we make it through here? Do you guys remember this? We can always just go through this stuff again too. It's never hurts. We can start here if that works. Yeah, let's start here. Okay, so we talked about Charlie. This was our scenario. Charlie was a bigger baby. He was born to a diabetic mom. He had some meconium stained fluid. Okay, so one of the things that Charlie's at an increased risk for is developing hypoglycemia. So let's go through this really quick. What do we see if a newborn has hypoglycemia? How are they going to present? What are some signs and symptoms?
They're going to be larger than normal for size, right?
Potentially. That's a really good point, Hope. I'm glad you said that. Who What population of babies is at an increased risk for hypoglycemia? A large baby is one of them. There's a couple.
If the mom's diabetic,
If the mom's diabetic, excellent. Let's see. Would a small for gestational age baby be at risk for hypoglycemia? Yes. So a large for gestational age and a small for gestational age baby are going to both be at high risk for hypoglycemia. They're both going to have poor um, glucose control. Another patient population that's at increased risk for hypoglycemia are preterm babies. Okay. Any preterm infant is going to be at an increased risk for hypoglycemia. I'm glad you said that because there's a couple of patient populations that we are concerned about or worried about. Um, and then babies that have problems with their bilirubin can sometimes have issues with glucose management, or babies that are in respiratory distress. If there's any other problem going on with the infant, the glucose level is something we're concerned about. So if a baby is hypoglycemic, though, what kind of clinical manifestations are they going to appear to have? Will they assess with?
Wouldn't they be jittery?
Yeah, they'll be jittery. Excellent. What else?
lethargic,
Yes, they could be lethargic. Definitely. So if they're lethargic, what's their muscle tone going to be like?
weak,
They're going to have poor muscle tone. Yep. If they're having a hard time maintaining their blood sugar, are they going to be able to appropriately regulate their temperature? Nope, definitely not. That's something that they're going to be compensating for with their low blood sugar, their temperature, their body temp, their low blood sugar. Their temperature is not going to be remaining stable either. So with these babies, they're going to be jittery, temperature instability. They could potentially go into respiratory distress. Do you guys remember we talked about this a little bit last week? If a baby is in a metabolic acidotic state because they're hypoglycemic and their body is trying to compensate for their low blood sugar, that could send them potentially into a respiratory acidotic state, and they could start showing signs and symptoms of respiratory distress. Okay. They're going to have poor muscle tone, so they're going to be hypotonic. They're going to be lethargic. And if it progresses to a certain level, if it gets severe enough, they can start having seizures. Okay. So 40 is our ballpark, what we want our blood sugar to stay above. Anything under 40, we are going to need to do some interventions. So, what should we do if our baby has hypoglycemia?
Feed the baby
Feed our baby. Yes. How often?
once an hour or once every 2 hours.
Yes, every 1 to 2 hours. These babies need to be fed very consistently. Okay. Um, we're obviously going to check a blood sugar, right? We're going to continue checking blood sugars. When do we check a baby's blood sugar if we're suspecting that they have hypoglycemia?
they're like 2 hours afterward.
So we want to check it before we feed the baby. So we want to do that because we want to see what baby's baseline is when they are not receiving any type of nutrition, when they're not getting fed. So we're going to check that blood sugar prior to a feed. That's going to give us the most accurate reading and tell us how our baby is doing. So here's what we're going to do. We're going to check their blood sugar before feeds. We need to make sure that level is above 40. We do this via a heel stick. And we need to make sure this baby is feeding every 1 to 2 hours. Okay. So our baby Charlie, he also, while he had problems with his blood sugar because he was born to a diabetic mom and he was also a big, large baby, we also remember in this scenario that he had meconium fluid. So something that we're worried about with this baby would be meconium aspiration syndrome. So with meconium aspiration syndrome, we're going to see signs and symptoms of respiratory distress. That's our biggest thing that we're worried about with meconium aspiration. So who can tell me what our signs and symptoms of respiratory distress are?
Cyanosis?
Cyanosis, yeah. All over the body, right? Not just the extremities, because just acrocyanosis is okay. What else could we see?
Tachycardic and retraction.
Yes, we're going to see those retractions, those substernal intercostal retractions. What could we potentially hear?
Grunting.
Grunting. Yep. Excellent. So let's see here. We got tachypnea, which is over 60 breaths per minute. We can experience some transient tachypnea in the newborn that can be occurring. But then we're also looking at grunting, nasal flaring, substernal intercostal retractions, some cyanosis, seesaw respirations, and apnea greater than 20 seconds. If babies have apnea that does not last 20 seconds, is that concerning, like periods of apnea in a newborn? Nope, that's okay. That's fine. But if we see those keywords there, I would know that. If apnea is greater than 20 seconds, that can be signs and symptoms of respiratory distress. So, what are we going to do? We're going to provide respiratory support. What else like do we do for a baby that's in respiratory distress? Like what kind of interventions? Let's start with first, how do we oxygenate a baby who's in respiratory distress? Are we going to give them 10 liters of straight oxygen via nasal cannula?
How are we gonna possibly like intubate if it gets worse?
Yes. So if we get to the point where it's progressing to where they're not able to breathe on their own, we're going to intubate for sure. What kind of oxygen do we typically administer to these babies? What form or method of delivery?
Like a valve mask.
So we give CPAP and PPV, so continuous positive airway pressure, and then PPV as well, we can administer. Those are the biggest things that we're going to do. So if our baby is in respiratory distress, we obviously want to tell our doctor, okay, this is not something that we're going to just handle on our own. We need them to come to the bedside and they need to assess this patient. We're going to try and stimulate this baby to cry. So that's rubbing their backs, rubbing their feet, rubbing their sides, rubbing their face, trying to get them mad so they cry, get up any gunk that might be in their throat, um, and get them to clear up those secretions. We can perform suctioning. So we talked about this last week, but we're suctioning with a bulb syringe, and we know that we need to suction our mouth before our nose. Um, but we also can perform deep suction. So that'd be like if you're suctioning a trach. However, now you're just suctioning out the infant's throat and esophagus. Okay. This is not something we do typically. Why would we not want to do deep suctioning continuously on a newborn baby?
Because you can stimulate the gag reflex
So
and
not
make
not super concerned about that, but you're on like sort of the right track in the throat. We don't want to,
You can cause bradycardia, also hypoxia.
yes, we don't
It
want to,
triggers the vagus nerve.
yes, exactly. We do not want to increase their risk for deoxygenation or hypoxia. So if you're going down with a suction catheter and you're suctioning out like thick meconium secretions, That's only so effective in clearing out a baby's airway. You also run the risk of sending them into more of a hypoxic state and worsening their respiratory distress. Okay. The only times that I personally have performed like deep suction on an infant is if we have intubated them. Okay. So this is something we're not doing very routinely. It's something you should almost avoid. Okay. We're going to be administering CPAP and PPV. CPAP, any type of pressure, continuous pressure is great because while it's expanding the lungs and helping inflating the lungs, promoting that carbon dioxide and oxygen exchange, it's also increasing baby's heart rate. Okay, so that continuous positive airway pressure and that PPV are going to do both things. They're going to stimulate our respiratory system and increase our respiratory effort and also increase our heart rate so that we're not bradycardic. We're obviously going to be monitoring these babies continuously. We need to put them on an SaO2 monitoring system and watch their pleth and make sure that they're oxygenating well. And yes, if we get to the point that the baby is in such distress, we are going to need to intubate the baby and provide breaths for them manually. Okay. In our scope of practice, nurses technically can intubate a baby in an emergency situation. I would encourage you, if you have access to a CRNA or an anesthesiologist, that you phone a friend because babies are very, very hard to intubate. Um, as you can imagine, everything is much smaller. It's a lot harder to visualize. They're a lot more fragile, so you run the risk of causing a little bit more physical damage than you would for a normal full-grown adult. So if you can, have somebody else do it, okay? We're gonna skip this because I don't love this video. All right, any questions about meconium aspiration or respiratory distress or hypoglycemia? Because we're gonna move right along, but you will see that stuff again later tonight. All right, so in our first 2 hours with our baby, we're gonna improve their thermoregulation. How do we do that? How do we keep our baby warm?
Drying them vigorously.
Yeah, we're gonna dry them. What else? What do we want to make sure?
Put the heat lamp on, the heat lamp on.
Uh-huh, we can get them under the radiant warmer if we need to, definitely.
What about skin to skin?
Skin to skin, yes, that's excellent. We want to put them skin to skin right away. That helps with thermoregulation big time. So let's see here. We're going to be drying. We need to remove any wet blankets. We need to make sure that the baby is only on warm surfaces. Place them skin to skin as quickly as possible. Make sure they've got a hat on and swaddle up that baby. Make sure they're nice and warm, protecting all that heat from escaping. Okay. So at delivery, after we rub them down, it's not been our 1 minute, so we don't need to do an APGAR just quite yet. We don't want to leave that baby sitting on that wet blanket, right? Because that can ultimately contribute to them losing body temperature and heat. So we want to avoid that, okay? We're going to get their vital signs. So can someone tell me what the vitals are and what the normal ranges are for everything?
Should the blood pressure be between 120 and 160?
For babies, it's lower than that. For this, I really mostly want you guys to tell me what's a normal respiratory rate and a heart rate and your temperature. We'll keep it simple today.
Is the heart rate 110 to 160?
Yep.
And the respirations are 30 to 60?
Yep. And then our temperature. I'll give you guys that one. It's 97.7 to 99.5. Respirations are 30 to 60. Heart rate 120 to 160, but 110 to 160 is fine. So these are the things that we're going to be assessing in our head to toe and as well with our APGARs, right? What measurements do we get on a newborn?
Circumference of the head,
Yep, we get their head circumference.
circumference of their chest, I think.
Sometimes that's not standard, but if for some reason there was like something flagged in their growth scans or something,
Mhm.
we might add that in. Yeah. Or if there was an injury of some kind. But we definitely do our head circumference,
Their length,
their length. Yep. And then one other one.
Weight.
Weight. Yeah. So we got our weight, our length, and our head circumference. Why do we want to get a head circumference?
Is it like to monitor for like hydrocephalus or if they have a cephalohematoma or anything like that?
Yes, excellent. So we are getting a head circumference at birth because we need a baseline, okay? So this is like somebody getting a hemoglobin before they go back for surgery. We just need a baseline because if something were to happen where they're showing signs and symptoms of having increased intracranial pressure, or their head is like getting bigger, or something is happening, or a wound on their head is expanding, we need to be able to accurately and appropriately measure that, okay? So, like for a cephalohematoma or a subdural hematoma, or even sometimes caput or molding, if we're monitoring it very closely, we need to be able to have a comparison head circumference from birth so we can tell if it's expanding or not. Okay. What are some signs and symptoms if a baby is having increased intracranial pressure? Specifically with your fontanelles, what do they do?
they protrude.
Yeah, they bulge. So for fontanelles, the soft spot on baby's head, if the baby is having increased intracranial pressure, that soft spot is going to bulge. If they're dehydrated, that's when we see the sunken fontanelles. Okay. If a baby is crying and we see that their fontanelles are bulging, are we going to panic? Is that something we're worried about? No, because anytime you cry, you're going to have a little bit of increased pressure, so that's okay. If they're crying and you see a little bit of bulging of the fontanelle, that's not something we need to be concerned about. But if they're at rest and their fontanelle is protruding or it's bulging, then yes, that is showing us that that baby is having increased intracranial pressure. All right, when we talk about newborn security, what does that mean, like in the hospital?
They have to have well, I think where we are, they do the hug system.
Yeah, the hugs system or the hugs tags, yeah.
Yeah.
And that's basically just to make sure babies don't get stolen. Another thing we have to do is put identification bands that have numbers that match baby to parents. And then if somebody comes up saying, "Hey, I'm here to hold baby Miller," you're like, "Okay, let me see your band." And if they don't have a bracelet on, then you're not supposed to give them that baby. Okay. So this is the added security that we have to have in place just to make sure that babies don't get taken off the unit. Those hugs tags that Joni was talking about are basically like babies, like they're like little ankle monitors. I don't want to say that, but it looks like they look like ankle monitors. And anytime you get close to a door on the unit, the door will automatically lock. And if someone were to take the baby outside of the unit, the whole entire hospital goes nuts. Like all the alarms sound, everybody has drills, it's a code Atom. So we're in lockdown at that point. Our assessment, we're going to assess for reflexes, a head to toe, and do all of those. We'll talk about the reflexes a little bit more, I think, in the next slide. What medications do we give our newborn, and what are they for?
Vitamin K so they don't clot, I believe.
So they don't bleed.
bleed.
You
Okay.
got it. You got it.
And and then the stuff they put on your eye, but I don't know what's it for.
So, yes, excellent. I love your glasses. Those are really fun.
Thank you.
Um, so yeah, the vitamin K is going to be a clotting, something to help the babies clot so that they don't bleed too much. Because like we know, babies don't make their own clotting factor until they're about 2 weeks old. So this vitamin K helps them so that they are not at a risk for an internal bleed or any type of bleed. Um, and then the erythromycin eye ointment is basically to prevent any type of conjunctivitis or infection of the eye, any gunk in the eye. Okay. Um,
Can I ask a question about that real quick?
yeah, for sure.
So we like I've had a ton of questions when I've done the NCLEX review about when the parent asks like what the erythromycin is for. And so like of course there's two answers and one you just said one is like this is if you have gonorrhea or chlamydia, blah, blah. And then the second one just says, oh, it like, then the nurse just says it's to prevent any kind of hospital infection.
Okay.
So, like, which is the right answer?
So it gives you those two choices was the between the two.
Yeah.
So I don't really love that. I mean, it's mainly because if babies are exposed to something coming down the vaginal tract, we want to make sure that we're giving them prophylaxis in their eyes to prevent them from developing any infection. So I would say it would go with along the lines of if mom was at a high risk for passing something to her infant. But like we give it to everybody, regardless if you have chlamydia or gonorrhea or not. So I would have to look into that and get back to you. Let me ask somebody who may have like already done those practice problems who's in on the like
Because
in
that is a Saunders question.
is it?
Yeah, I've seen it
Yeah,
like several
it's the
times.
chlamydia one. It's the chlamydia one. I did it.
Okay. I was gonna say probably that one. Because with a hospital acquired infection, I feel like anytime it asks that, you should just have a hand washing option and choose hand washing. But yeah, so we're giving the erythromycin eye ointment mainly to prevent babies from developing any type of infection as they're coming down from the vaginal canal. But that is kind of tricky. I don't love that. All right. So when we help moms breastfeed, what is our role in breastfeeding as the nurse?
Making sure they're latching correctly.
Yeah, we want to make sure their latch is correct. We also want to help moms feed every 2 to 3 hours or more often if they have if baby has, excuse me, hypoglycemia. And then if for some reason mom and baby are not together and mom still wants to breastfeed, we need to help her with pumping. So we need to tell her that she needs to pump every 3 hours for 10 minutes if the baby is in the NICU or if the mom and baby are not together. Okay, so we help them with pumping. So we're going to administer warmth before feeds to help draw the milk out, and then cold between feeds to help with soreness. All right. So we just talked extensively about Charlie in the scenario, the little baby that was born to this mom. Now we're going to talk about Jill and things that we're afraid of with Jill. So Jill is a G1P1 because she just had her baby, so she has one living child. She's a gestational diabetic that had a term spontaneous vaginal delivery 1 hour ago. Charlie was large for gestational age, so he's greater than 90th percentile, weighing 4,100 grams, 9 pounds. What complications could Jill be at risk for?
Hemorrhage.
Hemorrhage, exactly. Why is she at an increased risk for a hemorrhage?
She could have a laceration or a hematoma.
Yeah, she's at a risk for lacerations or hematoma for sure. So let's talk more about this. She is at risk for a postpartum hemorrhage because she could experience uterine atony, right? Which is our main cause of postpartum hemorrhages. Why are we thinking that Jill could be having difficulties with uterine atony? What about her history or this delivery would give us an indication that she could potentially have issues with her uterus contracting back to its regular size?
Because she's diabetic.
Nope, I wouldn't say that one.
Like, wouldn't a larger baby stretch the uterus out more, so it has to take that much more to shrink back in?
Yes, you got it. So she had a large baby. She had this LGA, large for gestational age baby. Is Charlie big because she was diabetic? Most likely, yes. However, when we're reading this, we see that baby was LGA, so she's at a high risk for uterine atony. Just like you said, Christina, whenever our uterus is getting to like the full expansion point, it's harder for the uterus to contract and return back to that pre-pregnancy size, right? So if a mom has a lot of amniotic fluid, or a mom is pregnant with multiple babies and her uterus is larger than what a normal pregnancy would be, she's at an increased risk for a postpartum hemorrhage because that uterus has to work a lot harder to shrink back to that size that it was before she was pregnant, right? So that's why she is at an increased risk for uterine atony. Okay. Um, so yeah, these are the things we're worried about. And obviously she had a big baby, so she's at risk for lacerations and hematomas because bigger babies can cause some more damage as they're being delivered. What are we gonna do as her bedside nurse? Jill starts bleeding like crazy. She's got clots coming out, all this crazy stuff. What are we gonna do? Your first action.
Oxygen?
Nope, not even oxygen.
Massage the fundus.
Yes, we're going to massage our fundus. So, our priority, and this is where people get confused in maternity because everything else is ABCs, right? Airway, breathing, circulation. If you see a question like this on your exam where you have a patient who's bleeding and who's hemorrhaging, think in your mind, what is the problem and how do I solve it? Our problem is Jill's bleeding. So what are we going to try and do? What's our priority? Is stop the bleed. The number one way that we stop a bleed with a uterine atony when a lady is hemorrhaging is we're going to massage that fundus. We are going to actively contract that fundus for her. We are doing the work of the fundus for the mom. Okay. Postpartum hemorrhages can get really scary really fast. I don't know if any of you guys have seen one or been in one, but just to like bring this in a real life example, I was taking care of a mom who she had a large baby. She was a gestational diabetic. We got through the first half an hour of recovery. The lacerations had already been repaired. Everything was good. And then all of a sudden, this mom passed out on me and she expelled about 1,000 out of blood clots in like a minute. Just would not stop. So the first thing I did was I started massaging her fundus continuously. The husband had to run out to the hallway to get help and reinforcements, and we ended up having to go back to the OR. And the mom almost had an emergency hysterectomy because she was bleeding so bad, and we couldn't figure out why she was bleeding. This case, I was massaging that mom's fundus all the way until we got her into the back and onto the OR table. Like you have to continuously be massaging this fundus, otherwise she's going to just continue to bleed. Okay? So it gets pretty intense. Postpartum hemorrhages, they're my least favorite. They are my least favorite. We do not love them. So what signs might the nurse assess if Jill was experiencing significant bleeding? If she was hypovolemic, how is Jill going to present?
She's going to turn pretty pale.
Yep, she's going to be pale, have some pallor,
Probably gonna get short of breath,
short of breath.
and then probably tachycardic.
Mm-hmm. Tachycardic, yep.
Low blood pressure.
Yes, low blood pressure, hypotension. Yes, you guys got them. So tachycardia, hypotension, oliguria, so she's not going to have very much urine output. Pale, cool, and clammy skin. What are we anticipating our order set being for this patient? We got somebody massaging a fundus. What else are we going to need to do?
Do they give oxytocin?
Yes, we're going to give some medication to contract that uterus. So oxytocin. We could also give our Methergin or our Hemabate or our Cytotec, depending on what the provider wants. If we have a mom who's lost a lot of blood, what else are we going to need?
Blood and fluids.
Blood and fluids. Yep. And with these patients, if they're hemorrhaging fast, we are getting emergent blood and we are pressure bagging it in if it's extreme. Well, that's like worst case scenario, right? But it can happen. So we need fluids. We're going to need oxygen. We're going to need 2 large bore IVs if you can get one. She's hypovolemic, so that sucks when you're trying to start a line on somebody who doesn't have any fluid. We're still massaging that fundus continuously through all of this. You better put her on the monitor, and you probably should get an EKG if you can, if you have like 3 leads that can attach to some monitoring system. And then we're probably going back to the OR for surgery to extract whatever might be up in the uterus causing the bleed, if it's severe enough. Okay. Postpartum hemorrhages get pretty wild. So, all right, let's do a couple practice questions here. The nurse is assessing a 38-week gestation newborn infant immediately following a vaginal birth. Which assessment finding best indicates that the infant is transitioning well to extrauterine life?
A.
A, cries vigorously when stimulated. So keywords here is transitioning well to extrauterine life, right? Heart rate of 220, is that good? No, that's not good. Even for a baby, we're probably going to be doing some monitoring of that. A positive Babinski, like, okay, yeah, that's awesome, but that doesn't tell us if the baby's transitioning well. Flexion of all 4 extremities, that is something that we want to see in our APGAR, but the best way to tell if a baby is transitioning is the crying, the oxygenation, right? Okay, a breastfeeding primigravida woman reports sore nipples on the 2nd day postpartum. What action is best for the nurse to take?
B.
Yep, assess the infant's position while feeding. Which action is most important for the nurse to implement to prevent bleeding in the neonate during the 1st hour after birth?
B.
Yeah, B.
Yep, we want to make sure that this baby isn't going to bleed, so we're going to administer that vitamin K to help them with their clotting. Which assessment finding would indicate respiratory distress in a newborn less than 24 hours old?
B.
Correct, nasal flaring. So let's talk about this one a little more. So we have a regular respiratory rate with periods of apnea lasting less than 20 seconds. Is that normal for a baby that's under 24 hours?
Yes.
Yeah, that can be normal. A respiratory rate of 50 breaths per minute is within our normal limits. And then abdominal breathing without retractions, that's also how a baby should be breathing. So nasal flaring is the oddball out here. And we definitely don't want to see that. After placing a newly delivered infant under the radiant warmer, the nurse provides naso-oral suction to clear the neonate's airways, which finding indicates that the infant is vigorous.
C.
Active movement and a lusty cry. Correct. All right, guys. Any questions on this PowerPoint? All right, let's keep rolling. We're going to get into week 8 content. And then we'll review. Okay, let's do a little bit of review over the stuff that we just went over here. What are 4 signs of respiratory distress in a newborn?
Nasal flaring,
Nasal flaring, yep.
abdominal breathing with retractions,
Mm-hmm. Retractions,
Grunting.
grunting.
apnea lasting more than 20 seconds,
Yes, excellent. You guys got it. Tachypnea, so breathing greater than 60 beats, respirations per minute. Retractions, grunting, nasal flaring, cyanosis, seesaw respirations, and apnea lasting greater than 20 seconds. What are 2 risks to a baby that is large for gestational age?
Hypoglycemia.
Hypoglycemia.
Clavicle injury.
Yes, birth injuries. Great job. So hypoglycemia and birth injuries. So yeah, we got those big babies. They're macrosomic. We're at a high risk for a shoulder dystocia, and with shoulder dystocias, our most common injury is a clavicle fracture. A newborn has been diagnosed with a cephalohematoma. What are we going to assess for?
Swelling, bruising.
Yeah, we can see some swelling, some bruising. We're going to monitor that head circumference, right, to make sure that head isn't getting any bigger. So the other thing we want to look for is jaundice. Okay. Anytime a baby has a birth injury, they are in an increased risk for developing jaundice because their body is trying to heal that wound. They're spending a lot of effort healing that injury point, and it can cause your bilirubin levels to rise, and then the amount of unconjugated bilirubin is going to increase, and the baby isn't going to be excreting it out fast enough. So that baby is prone to jaundice or hyperbilirubinemia. When assessing our APGAR score, which normal finding could the newborn lose points for? What's something that we see that is going to give us a point off of our APGAR?
the cry is not rigorous,
Not that one.
Acral cyanosis.
Acrocyanosis, yeah. What all are we assessing for our APGAR? Run me down through the mnemonic there. What is our A?
Appearance.
Appearance. So that would be if our baby is pink, if the baby is cyanotic or acrocyanotic. What is our P?
Both.
Pulse. Yep. So we want to make sure baby's heart rate is over 100. What's our G?
Grimace.
Yep, we're monitoring our grimace or how baby's reacting to external stimuli. What is our A? Our second A.
Activity.
Yes, activity. I always have to say it in order. Uh, Parents, pulse, grimace. Yes, activity. And then what's R?
Respiration.
Respirations. Yes, awesome, guys. So for your exam, you definitely need to know those categories and you need to know what score goes with which assessment. What are two priorities for the newborn at birth?
Drying them off.
Yep, keeping them dry. So that ultimately means keeping them warm, right? Make sure they're warm.
Airway clearance.
So we want to, yeah, make sure they're respirating correctly or respirating effectively. So respirations and thermoregulation, those are your two most important things at delivery. What are three newborn reflexes that we could assess for when we're doing our head to toe?
Babinski.
Babinski.
There's also the Moro.
Moral reflex. Yeah. What is that one called too? The other name for it. The startle reflex. So Babinski, Moro, what's another one?
Is that like the suckling reflex?
Yeah, we got all of these listed here. So we got our suck reflex, Babinski, the Moro, our startle, our rooting reflex, palmar grasp, tonic neck, stepping, and plantar grasp. These are all things that we would assess. What are the two newborn medications and what are their purposes?
Vitamin K to prevent bleeding.
Yep,
And I forget the name of the eye drops.
erythromycin eye ointment. Yes, you got it. Vitamin K to promote hemostasis, and then erythromycin eye ointment to prevent ophthalmia neonatorum. All right, let's talk about our reflexes here when we're doing a newborn assessment. So we have all these listed up here. What's normal and what would be concerning? So what is a correct Moro or an appropriate Moro reflex? What do these babies do?
Like when they're brought down, their like arms and their legs startle.
Yeah, they like go like this, like they're a little scared. They literally startle. It's typically if you make a loud noise close to their by them, or if you don't even have to make that loud of a noise on most babies, they just will startle like that. With our palmar grasp, what are we looking for? That baby's just gonna grab hold of your finger if you put your finger in their palm. What about tonic neck?
That's like when the head is turned to one side, their arm and their legs extend
Yes.
on the opposite side.
Yes. Yep. Good job. Our Babinski in a baby, we want there to be a positive Babinski. In an adult, we do not, right? That's a difference here. So the Babinski is when we're stroking the foot, the toes will flex, and then they can curl around here, curl around as well. Rooting is if baby's trying to find breasts, they're going to be like if you touch their cheek, they'll turn towards you with their mouth open. And then sucking is if you put your finger in their mouth and they suck down on your finger. So we're going to run down through our assessment really quick so that we can talk about what is normal and versus what is concerning. You guys did a great job on your teaching plans. And you included a head to toe newborn assessment, and all you guys did wonderful on that. So, with our head assessment, what's normal is that molding, right? Because that's just the normal shape that baby will take on to pass down through the vaginal canal. This is going to correct itself usually within a couple hours, if not the next day. Capit, same thing, that can be normal. We just want this head and our to be symmetrical, right? Abnormal is going to be all of these things listed here. This is going to be a lot of information on this slide, so if you guys need to take pictures of it, you're more than welcome to, okay? We're going to see if we see swelling of the scalp that does not cross the suture line, that is a cephalohematoma. If we have sunken or bulging fontanelles, that can indicate dehydration if they're sunken, or increased intracranial pressure if they are bulging. If we have an increasing head size, we're worried about hydrocephalus, and that's why we want to get that head circumference at delivery, right? Any low set of ears can indicate congenital anomalies. What specific congenital anomaly do babies have low set ears typically?
The down.
Down syndrome, yeah, Down syndrome babies have low set ears. And then cleft or lip palate, cleft lip or palate is gonna be something we're worried about as well. So with our respiratory system, our normal respiratory rate is 30 to 60. Irregular respirations is normal with periods of apnea lasting less than 20 seconds. That's okay too. Abnormal, tachypnea, grunting, nasal flaring, retractions, seesaw respirations, and cyanosis, respiratory distress. You guys are going to see all of these things like 8,000 more times because we want you to definitely understand this. For our circulatory cardiovascular system, our temperature should be 97.7 to 99.8, our heart rate 110 to 160. Acrocyanosis is okay, and some murmurs are fine. Okay. Abnormal, if baby is modeling, that is not good. If they have cool skin, lethargy, tachypnea with apnea, and bradycardia, because we're worried about non-shivering thermogenesis and cold stress that baby is compensating. Musculoskeletal. Our abnormal would be clubfoot and hip dysplasia. How do we know if a baby has hip dysplasia? How will they present?
That what is it, Orlani maneuver with the clicking.
You can listen for a hip click, yeah. What else would we see? These babies can have asymmetric gluteal folds with hip dysplasia. What about our clubfoot? What can we see with a clubfoot? What do their feet do? Do they turn out? Do they turn in?
They turn inward.
Yeah, their feet are going to turn inward with a clubfoot. So we need to know that. We need to know how we would assess for those things. Our genitourinary. We need to have one wet diaper in the first 24 hours, followed by 6 to 8 wet diapers after day 4. In a male baby, the testicle should be both descended. And then in a female patient, she may have a swollen labia, and that is normal. Okay. We need to talk about considerations and care for circumcision, a hydrocele, or cryptorchidism, which is just if their testicles haven't fully descended yet. So what are some things or some educational points that we are going to need to discuss with mom and dad if baby has had a circumcision?
Keep it clean and dry.
Yep, keep it clean and dry.
Change the diapers frequently.
Yep, changing the diapers frequently. Make sure that we're limiting the risk for infection. Some other things that we need to talk about with circumcision care is we always instruct the parents to put some type of like petroleum jelly on the front of the diaper so the diaper does not adhere to the baby's um, surgical site, I guess we can call it. And then what other things, like we're going to educate them about signs and symptoms of infection, right? um, and then, like, if a baby has a scab that's forming on the tip of the penis, are we going to what do we tell the parents to do about that? We tell them just to leave it alone. We don't want them to mess with it. Okay. So for their skin, what's normal is acrocyanosis. Milia is okay. That's those small white papules that can develop on the baby's nose or on the cheeks. We just tell parents to leave them alone. Erythema toxicum is normal, Mongolian spots. Neva simplex, which is your stork bites, and then vernix. That's all normal. Abnormal would be if they have a sacral dimple or tuft of hair above the sacrum or protrusion on the back, because we're worried about spina bifida. We can also worry that that could be a meningeocele or a meningomyocele. We're also worried about jaundice because that can show signs and symptoms of hyperbilirubinemia. And then cyanosis, obviously, that is always an emergency. Okay. All right. Hold on one second. All right. So just a reminder to everyone, during class time, you do need to have your screens on unless you have emailed me prior to class telling me that there's something going on that you cannot be on camera. Just because we got a big email this week that people have been like not in class and cheating, so they're kind of cracking down and watching our recordings for class time. So just during class, if you can stay on screen. If you have a medical reason or something going on that you cannot be on screen, that is okay. But if not, I need you guys to be on screen. Otherwise, I have to kick you out of Zoom, which sucks. I don't want to have to do that. But if anyone needs to take a picture, go ahead and take a picture of this. Because I know this is a lot of information. Oh, and obviously, if you have to go to the bathroom, don't like pee your pants or anything. Just send me a message. Okay, that's totally fine. No worries. All right, did everyone get this slide? Perfect. So let's do a quick case study here. Marie is a 32-year-old G3 P2002. She presents to the hospital in active labor at 35 weeks. She's 7 centimeters dilated and quickly progresses to delivery of a 5-pound male infant with APGAR scores of 9 and 9. What additional risk factors does this baby have compared with an infant born at 39 weeks? So this baby is 35 weeks. What would we consider this baby to be?
Preterm.
Yeah, late preterm. This baby's preterm. Babies 34 to 37 weeks, we consider late preterm infants. Okay. So we know this baby is preterm. What are they at an increased risk for?
Underdeveloped lung.
Yes, exactly. Why? What do babies that are this early not have enough of?
Because their lungs may not fully be developed.
Correct. What specifically, sorry, I'm not asking this correctly. What specifically do babies that are early not have as much of that a full-term baby would in their respiratory system? Sorry, what was that, Hope? I couldn't hear you.
The surfactant.
Yeah, surfactant. Excellent. Yes, so early babies have not fully been able to develop all of their surfactant necessary to help with lung expansion while they're trying to breathe, okay? So we oftentimes will need to intubate and give surfactant to early preterm babies to help them with this process. So babies that are early have a risk for respiratory distress. Okay, what else?
Challenges in feeding.
Yes, they're going to be poor feeders. Excellent. Because their suck reflex, the suck reflex is something that doesn't develop fully until they're a little bit later into their gestational age. So they're not going to be able to feed very well. These babies are also going to be more sleepy, okay? There's nothing harder than trying to wake up a 34-week infant to try and breastfeed. It just doesn't, they don't want to. They're tired all the time. They sleep more than even a normal newborn, okay? So if they're poor feeders, what could that mean for them? What else are we worried about then?
Jaundice.
Yes, jaundice.
Risk of like inadequate nutrition or weight gain.
Correct. Would we be worried also about these babies' blood sugar levels if they're not feeding well? For sure. So if they have if they have hypoglycemia, they're not going to be able to regulate their temperature either very well. So these babies are at a risk for becoming way too cold. So all of this ties in together, right? One thing offsets everything else, okay? So let's talk about this. We went through most of these things. So we are worried about respiratory distress in a late preterm infant. We can see apnea and transient tachypnea. Hypothermia is going to increase. We're going to have a risk for the baby not being able to thermoregulate correctly. Hypoglycemia is going to get worse. We're worried about that because, like Kristen said, they might be poor feeders. So their blood sugar is going to be low and they're not going to be able to regulate their glucose level. We also are running the risk of these babies having hyperbilirubinemia. Substantial. This can also often occur after discharge, requiring readmission. So baby's looking good, and then all of a sudden they get home and they're like, nope, don't want to nurse, don't want to poop. I'm going to turn yellow. We need to go back to the hospital. Okay. Kernicterus, we're going to talk about a little bit more later in this PowerPoint. That is a subsection of hyperbilirubinemia. It just is the metabolism of the unconjugated bilirubin in a different way that can have different outcomes for the baby. These babies also are going to be poor feeders. Okay. This is the number one reason why we don't send late preterm infants home typically within the normal rate that we would for a normal gestational age baby, because they're not feeding well and they're not gaining enough weight. They also are at a really higher increased risk for sepsis, and we're going to talk about why all of these things occur on the next slide. And it's another one you guys are going to take pictures of because it's a lot of content. Okay. So let's start with hyperbilirubinemia. They're going to have a decreased clearing of bilirubin and slower meconium passage to excrete it, because we know our bilirubin is excreted through our stool. Okay. If a baby is not feeding well because they're preterm, they're obviously not going to be pooping very well because they're not feeding well. They don't have intake, they're not going to have output. So those bilirubin levels are going to increase in their system. That's going to cause jaundice. Their TCB, their TSB is going to be elevated, and it's going to cause them to have these issues. Kernicterus is that has the immature blood-brain barrier, and kernicterus can occur with lower levels of bilirubin than in the term infant. Okay, we'll talk more about that towards the end of this PowerPoint. For feeding difficulties, these babies, when they're preterm, they lack the strength for effective suckling. They get tired very easily while feeding. They also have not fully developed that coordination between the suck, breathe, and swallow, so they have a harder time with nursing in general. This also, right, like we mentioned in the previous slide, can contribute to hyperbilirubinemia and hypoglycemia. If they're not nursing, they're not going to be stooling, they're not going to be passing that bilirubin in the meconium. They're at an increased risk for poor temperature regulation because they have less body fat, right? We talked about, at least a couple weeks ago, maybe last week. Brown fat is the stores that baby will use to regulate temperature because babies do not shiver to regulate their temperature if they're cold. They're going to burn through their stored brown fat. If you have a preterm infant that has not had the ability to reach full gestation, they have not put on enough adipose tissue, they have not developed enough brown fat stores, so they burn through their reserves very quickly, right? So they don't really have a backup compensatory mechanism if they don't have extra adipose tissue and they don't have that brown fat built up to help with they get cold, okay? With our hypoglycemia, they're going to have decreased glycogen stores, decreased adipose tissue, and then ultimately an increased metabolic demand because they have a relatively large brain size compared to the rest of their body and how their body is developed. Okay, so they're going to burn through all sorts of their reserves very, very quickly. And then last but not least, sepsis. They're at an increased risk of early onset GBS. Other risk factors include if mom's water broke prematurely and she was ruptured for a long amount of time, and if mom developed chorioamnionitis because she was ruptured for a long amount of time. Because like we talked about whenever we were talking about labor and delivery, sometimes if a mom's water breaks and she's 32 weeks gestation, providers are going to risk are going to weigh the pros and cons or the risk and benefit of keeping that baby in utero and administering antibiotics and monitoring fluid levels in the baby versus delivering early. So they may let mom go ruptured and treat her in the hospital and keep her in the hospital until baby has reached a higher gestation. But that's always on a case-by-case basis. So we need to just be very cautious with how we're handling these situations. Okay? If anyone wants to take a picture, go for it. That's the last little bit that's on this slide. I know it's kind of a lot to write down if anyone's taking notes. All right. So, respiratory distress in the newborn. You guys are going to get so tired of talking about this, but it's important, right? So we're going to talk about it for a little bit longer. What are some common causes of respiratory distress in a baby?
Being preterm.
Preterm, yes, a preterm infant for sure.
Meconium aspiration.
Meconium aspiration, definitely.
Pneumonia.
Yeah, if a baby has any other type of developing infection, for sure. Let's see, I think you guys got a lot of them. So these are kind of like the broad umbrella terms. Transient tachypnea in the newborn is often from inadequate fluid clearance, most common cause of respiratory distress, and it resolves within 24 hours. So basically, baby swallowed a lot of gunk on their way out. Respiratory distress syndrome due to a surfactant deficiency and hypodeveloped lungs. So they're preterm babies. And their surfactant isn't fully developed. And then meconium aspiration, if they swallow a lot of that meconium, they're going to have decreased gas exchange, inflammation, and can develop pneumonia. So who is at risk? Are meconium stained fluid at delivery babies, a C-section, infants born from moms that have maternal diabetes, prematurity, and infection. Why are C-section deliveries up there? Why is a C-section baby at a higher risk for respiratory distress?
Is it because they haven't quite like woken up in a sense, like by going through like the birth canal?
That is actually, you're on the right track. This is kind of a lengthier thing. So let's take it back to when we were talking about our 5 powers of delivery, passageway, all those things. So as that baby is moving down through the vaginal canal in a vaginal delivery, they're having contractions, they're having a lot of squeezing, they're having a lot of repositioning, and as they're coming down through the vaginal canal, their body is having that pressure, and then that release of pressure ultimately helps them clear out those lungs, right? So when we were talking about in my lecture, when we were talking about like transitional things that you're from a physiological standpoint that the body undergoes. So from a respiratory system standpoint, one of the things that happens is that pressure put on the baby, put on the body of the baby and on their system, that release of pressure when they're born is going to help expel that fluid and help that baby clear their lungs. And with a C-section, they don't have any of that taking place. They don't have any of that pressure. They don't have any contractions. They basically have a provider coming in, yanking them out. Here's life. Here you are, right? It's a much quicker form of delivery. And those mechanisms that are in place to help the baby clear the lungs do not occur during a C-section. So that is why C-section babies have a harder time clearing out their lungs. So they swallow a lot more fluid. They sometimes have gunkier lungs for a lot longer. They may have some transient tachypnea. And that's why we see babies with via C-section have harder time sometimes respiratory from a respiratory standpoint than we do with the vaginal deliveries. Okay. So Kristen, you were on the right track there. I just added to it a little bit. All right. What might we see with respiratory distress? We've said these things like 80,000 times. It must be important, guys, right?
Nose flaring,
Yep.
retractions,
Yep.
grunting,
Excellent.
apnea of more than 20 seconds.
Mm-hmm. Yes, we got it. I want you guys to get this ingrained in your brain. So I'm going to say it probably 5,000 more times. Our nasal flaring, our grunting, our central cyanosis, if babies are having retractions, apnea lasting longer than 20 seconds, tachypnea, hypotonia, and then seesaw respirations. You guys definitely need to know all of these for your exam, okay? What's our priority? If a baby is in respiratory distress, what do we want to do?
Oxygen.
Yeah, we want to oxygenate our baby. Let's keep it simple up in here, guys. We're oxygenating this baby. What orders, protocols, or plans of care are we going to anticipate for this infant? Your baby's in respiratory distress. You have them at the radiant warmer. What are some orders that you think you should have from your provider?
I don't know if like a CPAP would be would be in order.
Yeah, oxygen. Yeah, we're going to administer oxygen. And most of the time it's via CPAP. So yeah, that's correct.
Vitals, monitoring vitals.
Yes, we're monitoring this baby. We're going to put them on all the monitors. Let's think about our common causes of respiratory distress. We said that sometimes infections or pneumonia can cause respiratory distress. So what would we want to get potentially?
Antibiotic.
Blood work.
Blood work. Yes, we're going to get cultures, right? We want to rule out sepsis. We want to get potentially a chest x-ray. Because we want to see, is this pneumonia developing? Is this baby have a pleural effusion? Or are we looking at something more drastic like a pneumo, right? Especially with any type of birth injury, guys. If you have a baby that's born and you can tell that there's something broken or something that happened during delivery that may have put trauma on this baby, we are going to assess and make sure that this baby doesn't have a pneumo, okay? It can happen, for sure. Let's see. You're going to probably start an IV, right? And then if it gets drastic enough, an ET tube, and we're going to administer surfactant. Okay, so assess for gestational age, hypothermia, hypoglycemia, or sepsis. So basically, we need to determine what is the underlying cause of this respiratory distress. Because I've resuscitated babies where that's because their blood sugar was too low for too long. They're preterm. I've resuscitated babies whose temperature was poorly regulated because of their blood sugars, and then they went into respiratory distress. And I also have resuscitated babies who ended up testing positive for the flu or some random type of infection. So these can all be causes of respiratory distress, right? Because anytime we enter a metabolic acidotic state or any type of acidotic state, we run the risk of entering into respiratory acidosis, leading us to hypoxia and respiratory distress. We need to stimulate this baby to cry. We want them to clear out their lungs. We're going to suction. Like we talked about, we're going to use the bulb syringe, but we're going to be very careful when we're deep suctioning because we don't want to obscure that airway. Monitor our oxygen via pulse ox. We're going to administer oxygen, so CPAP or PPV or blow-by. Get a chest x-ray, administer surfactant, and sometimes we're going to drop a tube. Okay, all of these things you're going to do if your baby is in respiratory distress. There's this cute little guy with this little CPAP mask on and an OG. All right, before we talk about hypoglycemia, I got to run to the bathroom, so give me like a minute. Okay, I'll be right back. All right, thank you, everybody. So let's start talking about hypoglycemia here. We've talked about this before too, but who is at risk? What baby or patient population is at risk for hypoglycemia?
If their mother had diabetes or gestational diabetes,
Yep, babies born from a gestational diabetic.
and if they're large for gestational age,
Yep, LGA babies
And small babies.
and small babies. Yep, and then any baby that's having any type of distress, right? Respiratory distress, babies that are having issues with their bilirubin levels. So, babies born to a diabetic mom, LGA, SGA babies, preterm infants, late preterm infants, so those 34 to 37 weekers, birth asphyxia, any babies that are showing signs or symptoms of cold stress, babies that may or may not have an infection, and then hemolytic disease of the newborn. Okay, so jaundice or hyperbilirubinemia issues or anything like that. What signs and symptoms might we see or assess? How is a baby with hypoglycemia going to appear to us?
Jittery.
Jittery, yep.
lethargic,
Lethargic.
Blood glucose under 40.
Yep, their blood sugar is going to be low, definitely.
Possible seizure.
Possible seizures, yes. So you guys got most of them, yes. The jitteriness, lethargy, hypotonia, poor feeds, temperature instability, seizures, abnormal, weak or high-pitched cry, respiratory distress, blood glucose less than 40. So we're going over this stuff again, we're going over this quite a lot. So this is definitely things that we want you to understand for your exam and just in general in your nursing practice, okay? So as you can see, with hypoglycemia, you have respiratory distress, you have temperature instability. These three things usually go hand in hand in with each other. So if you have a baby who's cold, you have a baby who's at risk for having low blood sugar, you have a baby who's at risk for respiratory distress. You have a baby with low blood sugar. They're not going to regulate their temperature very well. They can ultimately go into respiratory distress. So you see how all these things are connected and affect the others. If our baby's blood sugar is low, what's our priority?
Frequent feedings.
Yeah, we want to get that blood sugar up. Feed your baby. Maintain normal blood sugar, normal glucose. For a hypoglycemic infant, what are some orders that we're anticipating? What do you think a
Blood
provider
sugar.
would tell us? Monitor our blood sugar. Uh-huh.
Feeding every 2 hours.
Yep, every 2-hour feeds. Feeding regularly.
Keep them warm because if they're not able to stabilize their glucose, they may not be able to regulate their temperature.
Yes, excellent, for sure. We need to help them. We need to make sure they're nice and warm and decrease any risk for respiratory distress or any other abnormalities. So we're going to put baby skin to skin with mom as long as possible. Why do we want baby to be skin to skin if baby is hypoglycemic? Kind of goes along with what we were just talking about.
Temperature.
Thermoregulation.
Yeah, temperature regulation and also skin to skin is just such a great regulatory measure. Okay. You put baby skin to skin with mom, it has shown to improve heart rate, respiratory rate, temperature, all of those things. So we want to keep baby as stable as possible when we're dealing with these blood sugar issues as well. Okay, so we're going to assess feeding ability, feed within the first hour and check blood sugar within 30 minutes of that first feed. Okay, that is the only time that we test the blood sugar after a feed is that first initial feed after baby's been delivered. Every other time, we're going to be testing it before the baby has nursed. Frequent feeds every 2 to 3 hours. We're going to monitor glucose before feeds for the first 24 hours. Glucose gel if it's low enough and it's indicated. And then IV therapy with dextrose. D10 is one of the only fluids that we can administer to a newborn outside of resuscitative measures via IV. Okay. D10 is what we are going to give a baby if they're having issues with their blood sugar regulation. Okay. What baby or what babies are at risk for developing hyperbilirubinemia and jaundice?
Preterm babies.
Preterm babies? Who else?
Insufficient milk intake.
Yes, if they're having poor feeding. Yeah, if a baby's not feeding very well. Definitely.
Bruising at birth.
Yes, birth injury, birth trauma. Yes, bruising. For sure. So, Are late preterm babies, traumatic birth causing bruising, so any baby that has a cephalohematoma, RH or ABO incompatibility, so that hemolytic disease in the newborn. If a baby is breastfeeding, they're at an increased risk for developing hyperbilirubinemia. Why is that compared to a formula-fed baby? Can we measure accurately how much a baby gets when they nurse or when they latch? But we can with a bottle, right? With formula. So typically formula-fed infants are getting a higher amount of mLs per feed than a breastfed baby. And say there's something that's wrong with the baby's latch, or their milk hasn't come in, or they're not producing a super large amount of colostrum, this can all contribute to just baby not feeding as much as they need to excrete the meconium and get rid of that bilirubin. So breastfed babies are going to be at a higher risk for hyperbilirubinemia and excessive weight loss. Any baby with sepsis or an infection is going to be at a higher risk, and then any baby born to a mom that had an intrauterine infection or any of those torch that we talked about. What signs and symptoms might we see? What is a baby with hyperbilirubinemia going to look like?
Yellow.
Yellow, yep.
High labs, like the bilirubin labs.
Yeah, their bilirubin's going to be elevated for sure. These babies too will be lethargic. So let's see. Oop, oh no. Back it up. Okay. We're going to see that yellowish discoloration of skin and eyes and high bilirubin levels. So signs of bilirubin toxicity, the encephalopathy, initially, these babies are going to be lethargic. They're going to have poor tone, poor suck reflex, diminished startle reflex, and a high-pitched cry. After the first few days, right, if we let this bilirubin continue to rise and rise and rise and rise, they're going to be irritable, they're going to have muscle rigidity, twitching, and seizures, and many infants can die if we let it get to this stage. Okay, so here's that kernicterus again. This is a neurological syndrome caused by the deposit of unconjugated bilirubin in the brain. This is associated with cerebral palsy. So can get pretty intense. So that is why we monitor every baby at 24 hours gets a bilirubin level drawn. Okay, that's part of our standard testing that we are doing in the hospital. So we need to pay really close attention to this and make sure that we catch it and recognize it early and treat it. Alrighty. Hyperbilirubinemia and jaundice. What's our priority for this baby? If their bilirubin levels are high, what do we want?
Frequent feeding.
Yeah, we want to lower their bilirubin level by frequently feeding them. So, what orders are we going to see?
Phototherapy.
Phototherapy, yep. What are some things that we want to consider with phototherapy? Someone explain to me what that is.
Phototherapy basically has the baby like in a sense like an incubator, but with the UV lights.
Hmm. These babies literally look like they're in a tanning bed. It's the same exact light. Like that and they have to wear those little goggles. So it is very much like they're in a tanning bed. What do we want to consider when we're doing phototherapy? Do we want them fully clothed?
No.
No, we want them naked except for a diaper. Okay. And obviously, they're going to be wearing that eye protection because the UV light can damage their retina. And so we're going to try and avoid that. We want to make sure that their eyes stay covered. So, phototherapy, excellent. What else are we going to anticipate for a Billy baby? A baby that has a high Billy level. If they're constantly under a radiant warmer, what would we need to assess frequently?
Their temperature?
Their temperature. And this is like kind of opposite of what we've talked about all day, but we want to make sure they don't get too hot. Okay, that UV light can sometimes emit some heat, and then in combination, them being under the radiant warmer, that can also cause them to overheat a little bit. So we want to monitor that. Can a mom breastfeed if her baby is getting phototherapy? She can. We want her to try and feed, but with limitations, right? If a mom is a first time mom and her breastfeeding takes about 2 hours for each feed, no. We're going to limit the amount of time that that baby is not under the UV lights or getting phototherapy. Okay. So we want to limit the amount that the baby's not under the lights, keep track of it. This is usually something we chart. We'll chart like phototherapy discontinued for feeding, phototherapy resumed type of thing. So let's see what we have here. So we're feeding our baby frequently. We're monitoring that bilirubin level. We're going to do the phototherapy, which we talked about. We also need to monitor for dehydration. So these babies, we're going to be doing INOs. We're going to weigh every single diaper and we're going to chart every single diaper that we weigh. Babies that get phototherapy and get treatment for bilirubinemia, they also usually get frequent weights. So we usually are weighing these babies at least almost before and after every feed to make sure that they're maintaining their weight. There's that baby, and I told you it looks like they're in a tanning bed. And this might surprise you guys. They do not like this. Babies don't want to wear these goggles and they don't want to be under this light. So oftentimes we are trying to console them, and it's usually if you have a Billy baby, it hopefully is your only patient. Doesn't always work out that way, but it should be. This little guy here is wearing a Billy blanket. So this is the Billy light. This is a Billy blanket. The Billy blanket we typically lay under the baby so that the back is exposed to the UV light. And then if mom is breastfeeding, we can wrap them up like that and swaddle them up like that while mom is breastfeeding so that they can still get some type of light exposure. All right, hypothermia. Who is at risk?
Preterm babies?
Preterm babies. Yes, it is safe to say preterm babies are going to be risks for all of these things. Awesome. Who else? We got our pretermers. Here they are, guys. Preterm, late preterm, very low birth weight. Any baby that has infection or sepsis, and then drug withdrawal newborns are at risk for being very, very cold and not regulating their body temperature. What are we going to see with the baby who is very cold?
A low temp?
Yeah, their temperature is going to be low for sure. Some other things. They're going to be bradycardic. They're going to have the mottled skin. They'll have acrocyanosis, and that's after that 24-hour period. They'll be pale, cold to the touch. They will not be feeding very well. They're going to be lethargic. They'll have signs and symptoms of respiratory distress, and this can also cause hypoglycemia. Okay, because we mentioned it's all connected, right? With our baby, this priority, we want to make sure that they are warm. Thermoregulation. That is our number one priority for this baby with hypothermia. What orders, protocols, or plans of care are we going to anticipate? Consider those things that we talked about or that I lectured on: evaporation, convection, radiation, and conduction. If we have a cold baby, what kind of orders are we going to see?
To keep them dry, monitor their temperature,
Mm-hmm, definitely.
warm blankets.
Warm blankets, yeah. So dry and remove wet towels immediately at birth, skin to skin, swaddling, place a hat on the baby, warm blankets, frequent temperature checks, radiant warmer for assessment, avoid baths, avoid drafts, and delay the bath. So for your guys' exam, you will need to know the evaporation, convection, radiation, and conduction, and like the ways that the heat is lost via those routes. So just for a little hint, hint, nudge, nudge, I would study that for if I was you. All right. Feeding difficulties. What are we going to see if a baby's not feeding very well?
Weight loss.
Weight loss. Yep. What else might we see?
Fussiness.
Yeah, they might be fussy. If it goes too long, they might start to get lethargic because they might be developing some hypoglycemia, right? So, all of these things we can see with feeding difficulties. They're going to have a hard time latching or shallow latch, so that baby's not latching on all the way to mom, okay? They're going to have that difficulty coordinating the suck, breathe, and swallow. If they're very sleepy or tired, they might be hard to wake up to feed. They might show signs or symptoms of like discontentment after feeds, so they might still be rooting around. They might be crying. They might be fussy. They may show signs and symptoms of respiratory distress while they're feeding if they're having a really hard time. We're going to see hypoglycemia, hyperbilirubinemia. They obviously are not going to be having the right amount of wet diapers. So it should be 6 to 8 after day 4, right? Um, they'll be lethargic. They're not gaining weight or they are losing weight. They'll have that sunken anterior fontanelle because they'll be dehydrated, right? And then the dry mucous membranes. So for this infant, we're going to want to feed this baby, right? That's our priority. So some orders that we can anticipate, we are going to need to wake them up. We're going to be hands-on with this patient, okay? This isn't just we go in the middle of the night and say, hey, it's time to feed your baby, and we walk out the door. We're going to be at the bedside, unwrapping the baby, making the baby uncomfortable, waking them up, messing with them throughout the feed to make sure they stay awake and latched on. If it's bad enough, we'll consult a lactation consultant. We'll help position mom for feeds. We'll look at the latch and make sure that the latch is adequate and that it looks good. We'll make sure baby doesn't have a tongue tie. So sometimes the baby's frenulum is connected too far up on the tongue and it won't allow the baby's tongue to extend all the way for a proper latch. So we sometimes will have to do a frenulectomy where the provider just goes in and cuts that little piece of skin, and that helps with latch. Sometimes we'll have to supplement with donor milk formula or pumped milk, a gavage feeding, and assess for signs and symptoms of hypoglycemia. Okay, neonatal infection and sepsis. Who's at risk? What babies are prone or at risk for infection?
Preterm.
Yep, preterm.
Moms had their water broken for an extended period of time.
Yep. Sorry, I clicked on accident. Yeah, if moms have had their water broke for extended periods of time. If they have a pre-existing infection, so like chorioamnionitis or group B strep, if their membranes have been ruptured for 18 greater than 18 hours, premature labor, preterm or late preterm birth, poor prenatal care, prolonged labor, birth asphyxia, or meconium aspiration. All these are going to put babies at a risk for infection. What's the priority for this baby if they have an infection?
Monitoring of their vitals, blood cultures, antibiotics.
So our priority is going to be early identification and treatment. And then our orders, you're right. We're going to get blood cultures, antibiotics, treat the symptoms, and encourage mom to still breastfeed. So with a baby who has an infection, how are they going to present clinically?
Pale, poor feeding.
Yep. Yep. Initially, they're going to be lethargic, poor weight gain, poor feeds, and be irritable. And then some vague and non-specific symptoms would be they'll have hypoglycemia, hypothermia, and be have signs and symptoms of respiratory distress. So then, respiratory distress symptoms, they'll have some tachycardia, decreased perfusion, temperature instability, and hypothermia, lethargy, hypotonia, jitteriness, irritability, high-pitched cry, and feeding intolerance. Awesome job, guys. We made it through all of our content. So why don't we do a little bit of review to finish up class today? Let me get that pulled up here. Maybe if it loads. Oh, let's try again. Okay, I got it. All right, go ahead and join. I'm not sure if everyone will be able to join just because I think there is a limit on how many people can play, but I'll let whoever wants to get in, and then we'll get started. All right, I think that is the max here. Okay. So if we have swelling that does not cross our suture line, that would be a cephalohematoma. Okay. Awesome. Everyone got it. Yep. Respiratory problems. If a baby swallows a bunch of meconium, we're worried about meconium aspiration syndrome and respiratory distress. So we need to be monitoring for that. A fractured clavicle. So our moral reflex is that startle response. So babies have to go like this. They both sides symmetrically have to react. So if baby has a fractured clavicle, they're going to have impaired movement on that affected side. So they're not going to be moving and throwing that arm around. They're going to be in pain and they won't want to. So their moral reflex is going to be asymmetrical if they have a fractured clavicle. Okay. So a baby that's born to a mom with diabetes is prone to developing hypoglycemia because there's a rapid drop in glucose and the baby is still secreting insulin. So in utero, that mom has diabetes, so she has a increased amount of glucose being produced or um, not being handled or managed very well in her body. So it's an excessive amount of glucose. So baby is used to having that high level of glucose, so they are producing insulin to counteract that in utero. When they're delivered and they're trying to regulate their own body system, they're still going to be producing that insulin because they're anticipating that glucose, that high glucose content, and it doesn't exist anymore. So it's going to drop the total glucose they're being exposed to is dropping, and the baby is still going to be secreting that insulin. Okay, so that's why we see hypoglycemia. So our post-mature neonate is going to have that almost leather-like dry, cracked skin, not very much vernix. They've been cooking for too long, so everything's starting to kind of dry out a little bit, okay? Yes, least effective here is the key. Make sure we're reading the question all the way through. So, which of the following actions would be least effective in maintaining a neutral thermal environment for the baby? Placing that crib close to a window for family to look at. We're gonna get a glucose. Awesome. You guys all got it. Yeah, this baby is showing signs and symptoms of hypoglycemia. We're placing the baby under the radiant warmer. So we know that babies are not able to regulate their temperature very well. So putting them under the radiant warmer is the best course of action. For an APGAR score, that's not really, we are not taking a temperature for the APGAR. The temperature is not something we're scoring on an APGAR. Okay. Yep. So with molding, we're not worried about it. The baby's head is formed to the shape of the birth canal and it should go away on its own. Sternal or chest retractions, an irregular heart rate, so like a murmur, or if we're auscultating something strange, like rhythm wise, that's not necessarily concerning for a newborn baby. We can auscultate some murmurs, and that's okay for a newborn infant. But any type of retractions is immediately a cause for concern. The Mora reflex, awesome, you all got it. Rooting, our rooting reflex. So this is going to be an indicator to mom that baby is ready to latch, is the rooting reflex. Okay. Our sucking reflex is something that baby should be doing when we latch to help assess our latch. But in order to elicit, for mom to know that we should be starting to breastfeed the baby, we are looking for that rooting reflex. Open and diamond shape. Great work, everybody. Yep, that's how our anterior fontanelle should look. So, this one, let's talk about it. Which statement indicates the parent understands the guidelines for bathing a newborn? Why would we want to wash a baby's head last?
So that it doesn't get cold. I mean, so that the baby doesn't get cold.
Yeah, so that the baby doesn't get cold. The baby loses a lot of its body heat from the top of their head. So that's why we're going to shampoo the baby's head last. We wash everything else and then the baby's head. Okay. Um, Washing from the feet upward and changing the washcloth for the face, I would say is probably incorrect because usually when I do it, I wash babies like private parts last, usually, and then I will wash their hair at the end. Yes, their pulse rate is too fast. An apical pulse of 178 beats a minute is way too fast, so that is abnormal. Yep, yellow. So the baby's stool is going to be yellow after 5 days after birth. So for the exam, guys, you're going to need to know your stooling chart for your baby, okay? When you'll see what color stool and what they mean. That definitely will be on your exam. Thirty-three hundred grams, yeah. So babies initially are going to lose a little bit of weight and then they'll slowly start gaining it back. So with babies, for little girls, they can sometimes have vaginal discharge that looks like blood. This is because that there's not getting that female sex hormone transferred from the mom anymore, which they get in utero. Okay. This is something we really need to educate parents on that can happen because some parents will get like very freaked out if they see this in the baby's diaper. And so we need to educate them that this is a normal thing that they can see, especially like with the baby girls. This isn't something that is a cause for concern. Infant's diaper is not wet after 8 hours. Yep, we are worried about urine output. If a baby refuses a feed, that is okay. We just need to make sure that they are not refusing the next one. But that's not something we need to call the doctor for just quite yet. If it goes on for a long time or a whole day, then yes, we need to take them in to be seen. But we're mostly concerned if the baby hasn't had a void in 8 hours. That can indicate they're very dehydrated or something else is going on. Yep, we tell them to leave it alone. We don't want them messing with it. All right. So I do have a meeting with a student now. So what I'm going to do is I will send you guys this. Let me stop this here. So I'm going to send you guys that link to the Kahoot review so that you guys can finish out the game and you can use it as you're studying. Okay. If you run into any questions while you're doing the review, don't hesitate to email me. But I do have a couple of meetings with students tonight that I want to get to. So um, if you guys have any questions, please email me. I will post that in the course cafe for you guys tonight. But other than that, thank you so much for your attention. You guys did awesome. This was a lot of content tonight. And let me know if you need anything while you're studying, and I will see you guys next week. Okay? Have a good night, guys.